Hi, meet Cody P. Dean. He is 21 years old, 6 foot, and a healthy 70 kilos. Recently, Cody's wisdom teeth have been giving him a bit of trouble, so he's gone to the dentist to get them removed. Cody was prescribed Codeine Forte for the pain. It contains 500 milligrams paracetamol and 30 milligrams codeine phosphate. He was told to take 2 tablets every 4 hours at a maximum of 8 tablets per day. But Cody's been wondering, what is pain? Well, the International Association for the Study of Pain defines it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. In addition, there are 4 definitions that Cody must acknowledge. Firstly, the pain threshold is the point beyond which a stimulus can cause pain, as well as pain tolerance, the highest intensity of painful stimulation that a person is able to tolerate. Of particular relevance to Cody's pain are the definitions of allodynia and hyperalgesia. Allodynia is pain due to a stimulus that does not normally provoke pain, and hyperalgesia is increased pain from a stimulus that normally provokes pain. There are also extraneous factors that affect pain. In Cody's case, these will most likely be sleep or lack of sleep, discomfort, and isolation as he recovers from the operation he has just received. Pharmacokinetics, absorption. Cody's medication is uncoated tablets taken orally. After ingestion, 90% of the drug is absorbed in the gastrointestinal tract and sent to the liver. Metabolism. Codeine is a prodrug and is metabolized in the liver by 2 subsets of cytochrome P450, 2D6 and 3A4, into 2 more lipophilic metabolites. 10% of the codeine is metabolized into morphine, which has high opioid activity and is highly lipophilic. The other metabolite is norcodeine, which has little opioid activity. Some people, including 5% of white Europeans, like Cody, are ultra-rapid metabolizers. This means that they produce more morphine given the same amount of codeine as someone with a regular metabolism. Distribution. The volume of distribution for codeine is approximately 3.5 litres per kilogram, and approximately 7 to 25% of codeine is bound to plasma proteins in the blood. Codeine has a half-life of 2.5 to 3 hours. The morphine that is produced in the metabolism of codeine is able to cross the blood-brain barrier due to its highly lipophilic properties. Excretion. Codeine appears in the urine approximately 6 hours after ingestion, and 90% of the drug will be excreted within 24 hours. The pharmacodynamics of codeine. The metabolite morphine is an opioid full agonist. It binds to mu, kappa, and delta receptors. These receptors belong to the G-coupled protein receptors family. In the diagram, we can see that the drug binds to G receptors in the extracellular fluid. The G receptor crosses through the lipid bilayer and binds to G protein in the intracellular fluid. This G protein inhibits adenylate cyclase, which results in decreased CAMP. This does 2 things. First, it closes calcium ion channels. This decreases the number of neurotransmitters that are released. Secondly, it opens potassium ion channels. This results in a decrease in neural excitability. This results in an inhibition of sensory transmission and alters the perception of pain. Pharmacological effects of codeine. Due to Cody's post-operative pain, codeine was prescribed for its analgesic effects. However, Cody may also experience the following: sedation or drowsiness, euphoria, and/or respiratory depression. Due to Cody's ultra-rapid metabolism resulting in an increase in morphine, Cody may experience heightened effects compared to a regular user of codeine. The issue with codeine in Australia. A recent study by the Medical Journal of Australia in 2015 highlighted that codeine-related deaths increased from 3.5 per million in 2000 to 8.7 per million in 2009. Interestingly, accidental overdoses accounted for 48.8% of the total deaths and were increasing at 9.3% per year. The study also highlighted that those with substance abuse problems and chronic pain were more likely to overdose accidentally. This could be due to two things. Firstly, dependence. Dependence can be defined as drug-seeking behavior despite a lack of therapeutic indication and despite adverse effects. This is the result of neuroplastic changes in the brain, which are particularly prominent in those with substance use disorders, and this can also lead to addiction. The second aspect, more likely to be involved in those with chronic pain, is that of tolerance. Tolerance can be defined as repeated doses resulting in a lessened effect. As a result, a higher dose is needed to attain the desired effect. However, a higher dose can also come with an increased risk of adverse effects, which include death. The study by MJA noted that those with chronic pain may have been taking codeine in addition to already prescribed pain medications. They may have also been compounding doses, that is, having one dose of codeine, not receiving the desired effect due to tolerance, and then taking another dose of codeine in a bid to receive that effect. However, in doing so, they have increased their peak plasma concentration well above the therapeutic window into toxic levels. This can lead to increased adverse effects, which could include a possible overdose and death. An alternative for Cody. Cody is experiencing acute nociceptive pain accompanied by some initial post-operative inflammation. Due to his age and good health, Cody could instead benefit from a paracetamol-ibuprofen combination. Studies in America by the American Dental Association show that this combination has similar analgesic effects while having less adverse effects. How are you feeling, Cody?
You know what, mate? I feel great.
Good on you, mate.